This week on the BackTable Podcast.
The awareness in the medical community to treat this stuff, unfortunately, it's making tremendous strides, but it's not there enough yet, right? Like we've gotten to the point where all the men coming into urology are getting their erectile dysfunction questionnaires, prostate, associated with their prostate cancer screening, right? Like I bet you, if you ask women who with a gynecologic malignancy or a urologic malignancy, like, are they getting sexual function questionnaires when they come to the office? Probably 0%, maybe 1%, right? So be your own advocate, because medicine is working to get there, but we're not there yet. So go to your doctor and say, I have pain with sex. I'm interested in this treatment. And fine, doctors don't like people consulting Dr. Google, but, I think there are instances where you have to be your own advocate, and this is one of them.
Hello, everyone, and welcome back to the BackTable Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Bagrodi as your host this week, and I'm very excited to introduce our guest today, Ashley Winter, who is a practicing urologist in Portland, Oregon. Ashley's a board-certified urologist who specializes in sexual medicine. She completed her residency at Cornell Medical Center and her fellowship under Dr. Irwin Goldstein, studying both male and female sexual medication. She's an associate editor of Sexual Medicine Reviews and enthusiastically shares her thoughts and perspective on sexual health. Welcome to the show, Ashley. How are you doing today?
Hi, it's fantastic to be here. I'm so excited to come on.
Absolutely. Really looking forward to having you. And, honestly, over the course of my career in urology, between interest in urology, residency, fellowship, I feel like sexual health, sexual function and dysfunction is something that's definitely gained a lot of interest and traction, but it's still somewhat in its nascency. And let me just ask you, are you seeing patients that seek out help to help manage their issues, problems that they may be having in the sexual function domain?
So that's a really interesting question. I have specialty training in this, although I work within a managed care organization currently. So it's not, I don't get patients coming to me in the sense of, kind of a tertiary referral center sort of thing. Within our organization, definitely people are directed my way. And you realize that when you have skills in this area, they're extremely in demand and very few people have expertise in them, right? Like I've become the go-to for all clitoris problems within our organization, and GYN will send people to me because they're not educated on clitoris problems, right? I mean, a basic one would be a clitoral phimosis, right? And sometimes they identify that and they're not taught to deal with phimosis, right? Urologists are. So it definitely comes to me. And then on top of that, as I have a practice that's somewhat hybrid sexual dysfunction for men and women, and also some general urology, you see that if you have basic skills in this area, it actually makes your practice in urology, general urology, and I think honestly, all aspects of urology much better. And I use some of these skills, on a day-to-day basis. So we realize that it's all cohesive, and you'll be a better urologist, and you'll actually have an easier time managing your patients when you have some basic skills in female sexual dysfunction. It's not, this esoteric, crazy stuff. It's just, management of genitals, which is what urologists do. So.
Yeah, I think it's a great point. I mean, any one of us treating patients, it's easy not to ask the question, even, a basic question like, how are things from erectile dysfunction perspective? It's one of those things where the patient may be waiting for you to bring it up. And if you don't, it's just going to go and they're going to kind of linger on. So is there a basic sexual history that you inquire about when you see, and maybe perhaps for the sake of focus, we'll hone in on women, but is there just a basic sexual history that you kind of intake on all female patients that you see?
So it's a great question. There are a few validated questionnaires. I don't use them in practice. The main one that's comprehensive is one called the Fsfi, Female Sexual Function Index. It's really long. I think if you have a specialty practice in FSD, it makes sense to use that. But if you're just incorporating basic FSD management skills into your urology practice, I don't think you really need to use that. There's also, if somebody's coming in asking about treatment for low sexual desire, there is specifically a questionnaire for that as well. And if we can touch upon that later, but if you end up using one of the FDA approved medications for what's called hypoactive sexual desire, then you can use that screening questionnaire. In terms of basic history taking, it depends what the patient's coming in for. So, if somebody says to me, hey, I have a kidney stone, or, they need a bladder cancer workup, then I'm not usually asking a lot of questions about this. Typical places where it does come up, right, is if somebody's sent to me for any sort of lower urinary tract symptoms in females, pelvic pain, recurrent urinary tract infection, because all of those things are intimately related, right? So a classic example is somebody that's sent to me who had been told for many years they have interstitial cystitis, right? And then you ask them, do you have pain with sex? Do you lubricate? Are you able to have an orgasm? How's your desire for sex? So just basic questions. It's not very sophisticated. I think you just have to remember that, your patient is a sexual person, and asking, basic questions about sexual activity and pain with sex are helpful. So.
Yeah, that makes sense. And, as I was preparing for this podcast and reading up a little bit on female sexual dysfunction, my understanding are the exact things that are the kind of domains, the things that you touched on, which would be desire, aka libido, I believe.
Yeah.
The ability to get aroused, have an orgasm. Is there any pain? Is that fair? Are there other aspects that we kind of touch upon?
Those are definitely fair. Within subsets, you can get more, specific. So when I have somebody come in for, any sort of pelvic pain or quote unquote, interstitial cystitis, I also ask about things like, do you have back pain? Do you have any sort of radiculopathy? Do you have, but this is kind of getting specific down that pathway, is your pain, obviously we like to think about pain associated with bladder filling, but is there pain with, sexual activity? Is there pain with certain positions? Because, as we'll get to later, the pelvis is full of organs that are not the bladder. And oftentimes when patients are coming in with basic urologic complaints like, pain with bladder filling or, urgency frequency, this is actually related to things like your pelvic floor muscles or, lumbar sacral spine disease. And when we think about classic urologic symptoms more broadly, then we're able to actually find better interventions that are more specific to the root cause.
So it also seems intuitive that sexual dysfunction can absolutely be multifactorial, including relationship status, previous history of, I'm an oncologist, cancer treatment, radiation, surgery to the pelvis, hormonal status, menopausal, postmenopausal, psychological anxiety, depression. And, this isn't like straightforward necessarily. So how do you kind of break down your targeted history when you're, again, inquiring about things that may be impacting sexual function, again, whether that's arousal, orgasm, pain, and so forth?
Yeah, great question. So I think one of the main issues that holds people back from getting involved with female sexual dysfunction is this idea that it's complex and vague, and it's this mountain you cannot conquer, right? And the comparison I'd like to make is, when we think back to male sexual dysfunction, in probably the 70s, you said, oh, you can't get an erection, you need to go see a psychiatrist. And we thought it was, only mental. And obviously we know that it's a biopsychosocial phenomenon, right? So obviously counseling and therapy and understanding interpersonal dynamics is super important. But, it was kind of revolutionary when we said, hey, you can give intracavernosal injections. Hey, you can give this ED pill, and that it is something you can add physical interventions on, in a very real way. And I think, with female sexual dysfunction, we're several decades behind, and most, even on a broad cultural level, you say, oh, a woman isn't enjoying sex, have a glass of wine, right? There's still so much of that narrative happening instead of, oh, you're having sexual function issues, not, what, is there any issue with your clitoris? Is there any issue with your vagina? We don't think about it that way as a first line. And it's not that it's only physical or only mental, but there are often things that can be intervened on that we're not coming to.
So how about like, let me maybe throw some out there. History of chronic kidney disease, history of cancer. Are those ones that you've seen can impact any of the parameters that we've talked about?
Sure. So let's say if we're starting with low desire, right? Or not, let's say, yeah, if we're starting with low desire, right? So history, you would ask about our medications that intervene upon your hormones, right? So oral contraceptive pills, for example, do lower bioavailable testosterone in females 100% of the time. It doesn't mean that it always causes sexual dysfunction, but this is something that's very poorly understood by the general population, right? Oral contraceptive pills don't give you more hormones. It's a low dose of a synthetic hormone that will suppress basically your ovulation, and then it actually raises sex hormone binding globulin, which lowers testosterone. So that was me digressing, but basically, history of any sort of contraceptive, obviously, history of something like breast cancer and, medications that suppress hormone levels.
How about post-pregnancy?
Totally. Huge part. So lactation, is a period of time that leads to suppression of hormones, and you can have actually pain with sex especially during lactation, and treatment with vaginal estrogen is actually really common in that subset. And so, yeah, I mean, these are huge things. So contraceptive, lactation, obviously cancer treatments, vulvar disorders, which is something that I think most urologists, unfortunately, are poorly educated on. But, lichen sclerosis can really have a big impact. Obviously, radiation treatments for cervical cancer. Obviously, this is a big one recently in the urologic community, talking about cystectomy, and realizing that women with post-cystectomy still are humans that may want to be sexually active.
How about medications such as antidepressants and beta blockers? I mean, these are ones that I'm actually thinking about from the male side that can impact, libido potentially or sexual function.
Yeah. So SSRIs are a notorious one, that, as we know, in men can lead to delayed ejaculation or difficulty of achieving orgasm. It's certainly the exact same phenomenon in females. Beta blockers, I'm not sure how well that's been studied.
Okay. And then, this is obviously going to be a sensitive aspect, history of abuse, strained relationships. Is this something that may come up from the patient end once you start having this conversation, or do you broach it? You're kind of wearing multiple hats, I suppose, when you start entering this area of sexual function.
Yeah, that is definitely a very sensitive area. In my intake questionnaires for my clinic, we do have a question: do you have any history of abuse? I think that can be a good place to ask that information, at least as an initial screener, because I think most people are not going to, in their brief urology encounter, just be able to pop in and say, hey, I've been abused before. A lot of people aren't going to get there. So I think it gives people an opening, to initiate, for you to kind of prod that line of questioning. And I do think you could tell pretty frequently when somebody feels like, emotional and psychiatric components to their sexual dysfunction are really at the forefront. And most patients will kind of say that to you. And I think in those sort of situations, and I know achieving a multidisciplinary team is going to be the real key there, right? And, for anybody in the community who's saying, how do I get partners in that space? There is this organization, ASECT. So that's, if you look it up, it's AASECT.org. And that's the American Association of Sexuality Educators, Counselors, and Therapists. So if you want somebody who's, a social worker, who's a therapist, who has real credentialing in doing sexual dysfunction and sex therapy, that's really my go-to for finding people. And they have a find a provider website. So you could even, look at who's in your community, reach out to them, see if you can start, kind of some sort of, kind of referral pattern. And that's an easy thing to do. And I think most of us acknowledge that we're not ever going to be sex therapists, and that's okay. So.
Yeah, that's super helpful. I mean, I would imagine a multidisciplinary team could involve psychologists, physical therapists, exercise therapists, pelvic floor physical therapists, sex therapists. I'm not sure if that's more of kind of a niche thing. Well, this is, I think the intake, I mean, obviously it could take so many different directions, but maybe jumping into the physical exam, what are the things that you're really kind of dialing in on now?
So, kind of starting, I'd say top to bottom, right? So if somebody's coming in with sexual pain, I always do a basic examination of their back, right? So you can palpate the SI joint, you can palpate along their back, in the midline. And then when you do your genital exam, so there's a lot of things you're going to look for. So the first thing, if we start at the clitoris, right? I do recommend people examine it, right? I think it's like the most ignored organ of the whole external body. I mean, when I was starting as an attending and in my current job, and we were going over billing for documentation of comprehensive genital exam, the male exam had all the typical things you would think of, right? I mean, penis, scrotum, testicles, prostate exam. And on the female exam, the word clitoris didn't even come up. Now, I think, billing guidelines have changed since 2017, but I just was flabbergasted at the fact that this organ, which is, the embryologic homologue of the penis, was like not even on there, right? It's crazy. I mean, it's a small organ. It doesn't mean that it's not highly functional, right? I mean, so it's right there. How do you examine it, right? So basic things to remember, right? The visible part of the clitoris is essentially homologous to the glands of the penis. It has a prepuce, right? That's the clitoral hood. And because it has a prepuce, it can get a phimosis, just like a penis. And as a urologist, we can understand that concept. It's pretty basic. So, you put your hand kind of above the clitoris and you try to pull up the hood. And if you can't see it, then the person may have a clitoral phimosis. It's common in conditions like in sclerosis, but it can be present in people who have no other history. So I've had somebody come in to me and say, like, they thought they had bladder pain or they thought they had interstitial cystitis, and then you ask a little more and you find out that they have, pain with arousal, and they had a clitoral phimosis. And it actually was like this painful, like they had balanitis of their clitoris. And because the clitoris, kind of extends deeper, into the pelvis, they were experiencing kind of these radiating pain symptoms. And, essentially you can, do a dorsal slit of the clitoral hood, and it takes probably 2 minutes, and you can make a dramatic improvement in somebody's life, right? And so that's something that if somebody said, go, drink a glass of wine and get a therapist, you want to fix the problem, right? But you can fix that problem as a urologist. So that's the first thing, right? You can basically try to see if the clitoris is visible. Typically, you would expect that the typical kind of clitoris gland size to be around the size of a Q-tip, the tip of a Q-tip. If it's really minuscule, that may indicate kind of a lack of testosterone. And right, we have to remember that physiologic range of testosterone in females is about 1/10 of a physiologic range for males. I hate the common messaging that testosterone is the male hormone and estrogen is the female hormone. If you actually look at these molecules like on a one-to-one basis, because they're all sex steroids and derived from each other, actually the average female has more testosterone than estrogen. So it's actually an everybody hormone, and it's incredibly important for sexual function. So that can be a sign on physical exam of kind of low subphysiologic testosterone levels. So that's kind of starting at the top. Then if you think of the vulva, right, you have the labia majora, the labia minora. Those can also be fused, which would be something that could lead to pain. Commonly, example, it would be something like in sclerosis or post-radiation. So, you look at that. Then moving internally, you have this critical space called the vestibule. And this is something that's between the inside of the labia minora and the hymenal ring, okay? And the opening of the urethral meatus sits there. And this is, again, going back to kind of homologs, right? This is the homologue of the penile urethra. And interestingly, if you look at people having transgender surgery, female to male, they'll actually take that tissue and tubularize it to make the urethra for a neophallus. And you're like, why is she getting on this tangent, right? Because irritation of that area very commonly causes urinary symptoms. Okay. So in your classic postmenopausal patient who thinks they have a UTI all the time, but has negative urine cultures, irritation of that tissue from hormone deficiency can be the cause of those symptoms. It can make you feel like it hurts when you pee. Irritation there can make it feel like you have to pee all the time. It can make you feel like you have a UTI when you don't have one. So you look at that tissue, this area of the vestibule, and you look if it's, red, irritated, paleness of that tissue, right? It should be like pink and healthy, can indicate hormone deficiency. Also, look at the caliber of it, right? I mean, I think we've all examined somebody who's, 80 years old, and, the introitus or the opening of the vaginal area is just, probably like the size of the tip of your finger, right? It's not supposed to be that way at any age, right? I mean, yes, it's part of normal aging, but that's associated with horrible symptoms most of the time. And it's something that can be managed, right, by having these patients use hormones. So there's that. Obviously, the urethral meatus is something, you look at. Again, if it's pale, if there's prolapse, those can be signs, again, of hormone deficiency or postmenopausal status. And then, in terms of a speculum exam, I mean, I don't really look at the cervix or kind of that aspect, too frequently. I think that's more GYN domain. Certainly, you can take a look in there, make sure there's no like severe lesions or anything. And then, when I'm moving into the vagina, the typical thing I'm doing, honestly, is a pelvic floor exam, right? So you basically put your finger in, you turn your hand around, and you kind of press downwards, and you're going to feel the levators, and, you say like, does that hurt? Right. Another trick, right, is if you move your finger kind of to the side and have the patient push their knee outward against your hand, you're going to actually feel the obturator internus. So, and that, if they have real severe pain with that maneuver, can actually be an indication that pelvic floor dysfunction is the origin of pain with bladder filling, for example, right? And that's somebody who's really going to benefit with sexual pain, with urinary tract symptoms by going to a pelvic floor physical therapist. So, I'd say, to summarize that, right, do some basic physical exam maneuvers of the back, examine the clitoris, look at the labia, vestibule, super important. You can also palpate that with a Q-tip to see if it's painful, and then go ahead with your pelvic floor exam, some basic maneuvers. If you feel not confident with pelvic floor exams, I would encourage any urologist to go to a pelvic floor physical therapy like weekend course. I went to one once, and it was probably the highest yield, like 3 hours of my life. And it was a better physical exam training than I ever had in all of residency. I did that as an attending. It was amazing. So consider doing that.
Yeah, I think it's critical. And, I think it's easy to gloss over, remember an experience in residency where a junior resident was trying to get a catheter in an obese female, and she was trying to intubate the clitoris. And I mean, it was a tough exam, but just familiarizing yourself another time sounds incredibly valuable. Now, I know some of this is going to be kind of symptom specific, but routine labs or imaging that you're obtaining on patients with chief complaints of sexual function disorders?
Yeah, definitely depends. There's not too much usually you need. For example, if you're, treating a hypoactive sexual desire postmenopausal female, you don't really need to do a hormone panel. I think if they're younger and you're looking to see kind of their hormone status, you can do a testosterone level and an SHBG just to see what their level is. Some people have like just dramatically low or almost undetectable testosterone levels, probably due to contraceptive use. And then basic things like checking, TSH, things that you would screen when you're looking for sexual dysfunction in male patients as well, checking an A1C, right? Are they having like lack of sensation or arousal because of, diabetic neuropathy, which affects female sexual function as well as, male.
All right, so not an extensive panel of FSH and LH and testosterone and prolactin, typically kind of as your first line evaluation. Is that fair?
Yeah, I mean, I'm not typically doing that. If there's some concern for like if they're having visual effects that you think they might have a elevated prolactin, or if they're on certain psychiatric medications that can really elevate their prolactin, you can check that. I'm not routinely checking prolactin. I think also, if you're going to be very sophisticated with this, you could certainly debate doing more extensive workup. But I think for the average urologist, you don't have to kind of go deep down that pathway.
So maybe now let's kind of start jumping into management, and again, if it makes sense, perhaps we could talk about desire, arousal, orgasm, and pain. So starting out with desire, low sexual desire.
Yeah.
We've kind of done our targeted history. We've gotten our exam in, and how do you start chipping away at that?
Yeah. So if you're doing low sexual desire, right? I mean, the term most frequently being used for this now is hypoactive sexual desire disorder. The way I think about this is, I want to want it, but I don't want it, right? Obviously, if somebody's not interested in sex and they're not bothered by it, that's not a problem, right? We're not here to tell everybody, hey, you have to be a robust sexual being, I mean, whatever. Like, if you're not bothered, fine. But if you're not interested in sex and you're bothered by it, then that's kind of what we consider hypoactive sexual desire. And that can be the case in men too, right? I mean, this is a universally applicable issue. So there are, in terms of intervening on that, I'd say the first thing is obviously making sure that there's not another reason why. Like, are you not interested in sex because it's painful? And then you go down that route, right? You have to address that. And that is the case, right? So you can't say, oh, somebody has horrific pain with sex and then start giving them all this stuff to make them horny. Like, that's not going to fix it, right? So you do address all of those. But if that has all been addressed and you have somebody who's coming like hypoactive sexual desire disorder, again, there is a screener questionnaire for that. It is pretty simple. You can find it like on the websites for the pharmaceuticals for low sexual desire, and it's called the Decreased Sexual Desire Screener. And anyway, so in terms of the kind of the treatments for that, so if I have somebody who's perimenopausal or postmenopausal, my first line treatment is to actually give them testosterone, and at a physiologic female dosing. There's a consensus statement. If you want to learn more about use of testosterone in women, there's a consensus statement from the International Society of Sexual Medicine. You can find, I would have to find the exact article, but you can find it. But regardless, there's good data to support this. There's even a Cochrane meta-analysis looking at testosterone supplementation in women, showing that, in postmenopausal women, there's a benefit for low sexual desire. You really don't need to do lab work to diagnose that. You can presume if somebody's postmenopausal that they're going to have reduced testosterone production. And the way you dose it, so unfortunately in the United States, there's no FDA-approved testosterone formulations specifically for physiologic cisgender female dosing, which is really pathetic. But I think there's been attempts to make it happen, and they haven't been approved by the FDA. So the easiest way to do it is to take like a testosterone gel that you would prescribe for a guy. And because you're thinking about doing this at 1/10 the dosing, you just have them use that over the course of 10 days. Now, when you have a packet that can be kind of messy, there are actually, 1% testosterone gels that come in once a day tubes. And that's the easiest one. And then they can, just use that on the back of the calf over the course of 10 days. If they use the tube up sooner than that, then, they just don't use any more for a few days. And it's fine. So it's actually super simple. A lot of insurances, or probably almost all insurances, won't cover this, which is really sad. Thankfully, because it's they only have to buy a 1-month supply, and that basically covers them for
takes
the whole
them through
year.
a year.
Yeah, exactly. And generic testosterone aren't super expensive. So usually you just say, don't worry about getting, there's no prior authorization that's going to get this. Don't waste your time. Just buy it, and you'll get a whole year's out of it. So that's super easy.
And do you have to follow labs like hemoglobin hematocrit, or is that at those levels not even going to make an impact?
it's not going to make an impact. That's the amazing thing about so many of these treatments. They're so easy. Like they're easier than doing it with males. I mean, people are not at those levels of T supplementation. Nobody's going to get polycythemic.
Okay.
Like, yeah. I mean, I will say if there's any concern that somebody has virilizing symptoms, then you can check a T level. I had a woman come to me because she was having actually bladder pain, and I did an exam on her, and she had massive clitoromegaly, and it turns out she had been going to a naturopath, who was overdosing her on testosterone, and she had a testosterone level of like 800, right? And this is not somebody who's on like gender affirming hormone therapy. Like this was somebody who just went for low libido, and they had been so
Yikes.
If they have any virilizing symptoms, then just check a T level. For some reason, they might have been using it wrong, but you don't have to follow it. So, and then in terms of non-hormonal approaches to HSDD, so there's 2 FDA-approved drugs. One is called flibanserin. The other is called bremelanotide. The nice thing is because these are FDA-approved, there's tons of resources from those websites. So you can because they want you to prescribe it, obviously. So there's tons of educational material. Flibanserin is a once-a-day pill that you take every day. It's a selective serotonin agonist, antagonist. It works in the brain, non-hormonal. It's technically FDA approved for premenopausal females. Certainly, I've seen people give it postmenopausally, although you want to address hormones first. And I've also seen people use it in men, actually with excellent results, because it's non-hormonal. And it's a lot of people love it. Increased desire, increased improvement with orgasm, arousal, like lubrication, all these amazing things. Initially, a lot of people were concerned about it because they had a black box warning that you couldn't use alcohol and flibanserin at the same time. That has been removed. And it was based off these crappy studies where basically they took some test subjects and gave them flibanserin, and then on an empty stomach first thing in the morning, they had them drink like a bunch of alcohol and they got dizzy. It's just, it was just like ridiculous. I mean, it was just like sometimes, safety trials don't correlate with real world
real
stuff.
life.
Yeah. So don't be scared of that. There actually are side effects of, kind of improved sleep quality, and the average patient taking it does lose a little bit of weight. And that was like, so there are some other aspects of it that people find beneficial. And it's really useful in people, let's say, who have sexual dysfunction associated with being on some sort of psychiatric medication that they can't stop, right? So let's say somebody has severe depression, they're on an SSRI, and they really, and you'd love to say, oh, stop that, and you'll be able to orgasm again. But maybe if that person stops their high dose of SSRI, they have severe depression or they're suicidal, right? Like you can't stop that. But this is an amazing drug for somebody with those side effects. I wish I could give it to men too. And you can, obviously, because as providers, we can use things off label. The problem is almost no insurance is covered, and it's a new drug, so it's expensive. But I'm a huge fan of that. And then the other one, bremelanotide, is basically that's the on-demand medication. So it's a melanocortin receptor agonist, and it's actually an auto-injector, and you take that about an hour before sex. And you inject. So that's like if you don't want a continuous dosing thing and you want to do it on demand. And I think, if a patient comes to you and you've diagnosed them with HSDD, which you can do easily through that screener questionnaire, that's like 4 questions, you have those 2 options and you say, hey, are you interested in something that's, kind of continuous dosing, or are you interested in something on demand? And those are the 2 main options. So, I encourage people if they're interested in to start prescribing these things, it can make a huge difference in your patient's life, and it's not that hard.
Yeah. I mean, full disclosure, honestly, prior to preparing for this podcast, I'd never even heard of those medications. And, it is what it is. It's a little bit embarrassing as like a practicing urologist. But the fact that there are options, both hormonal and non-hormonal, that have, shown very strong efficacy is incredible. And do you have a ballpark for what the incidence of hyposexual desire disorder is? Because I have to imagine that this is one of those things that's like 30% of women, are affected by HSDD.
I think it's massive. And again, it's so many layers, right? I mean, yes, it could be a relationship issue. It could be, there can be a hormonal component. There can be stress. But that said, there are providers who are like, well, you can't just throw this drug at people and not address the root cause, right?
Right.
My argument would be you need to do both, right? I mean, that's like saying nobody who has depression should be on antidepressants. They should all go to therapy until they're not sad anymore, right? I mean, like we've realized that's not a fair, it's a false choice, right? So yes, that person, if they have relationship problems, needs to address it, blah, blah, blah. If they need to go to therapy, they need to go to it. But if there are safe, FDA approved, effective options, do it, right? And on top of that, like there are so many layers where it factors into each other, like these things roll into each other, right? Like I'm not interested in sex, and because of that, my relationship is stressed, which makes me less interested in sex. But if I took this like pill and I was like, oh my God, I'm so interested in sex now. And, me and my partner are suddenly having more sex and then we're happier. And that could address one of the root causes. So I think, we just have to get over the idea again that like sexuality is siloed from other forms of healthcare. Embrace this sort of thing the way we've embraced erectile dysfunction.
Absolutely.
The other thing that I hate with this is that they're commonly called like female Viagra, which is just complete garbage. Like female Viagra would be Viagra, right? I mean, the clitoris is a homologue of the penis. If somebody wants to improve their clitoral rigidity, they could take Viagra and, and it will have the same effect on the corpora cavernosum of the clitoris. I mean, that's it. And honestly, also by vasodilating, you can actually improve lubrication by taking Viagra, like vaginal lubrication. So that's the female Viagra is just Viagra. These medications, blue melanocyte and flibanserin are, centrally acting non-hormonal treatments. So it's just, it's totally different.
So I think sounds to me fairly comprehensive for hypoactive sexual desire disorder. What about for issues and problems with arousal and ability to have an orgasm?
Okay. So the first thing I would say is examine the clitoris, right? Just because that is something that's super easy to intervene on if they do have a clitoral phimosis. So that's number one. I'd say a second thing, obviously, is it's education, right? I mean, it's horrible for me to say this, but the number of women who come to me and say, I can't orgasm, I am upset about this. And then it turns out that they still thought that they should be able to orgasm from penetration is insane, right? Like I've had women who are like 50 years old say, I've never been able to orgasm. I'm like, have you ever bought a vibrator? And they're like, no. That's crazy. I mean, we all know that it's normal for women to orgasm through clitoral stimulation, and very commonly normal for women to not be able to orgasm from penetration. But a lot of people don't know that. So actually just ask people like what their expectation is. And it will turn out maybe that nobody's ever stimulated their clitoris. And if they try that, then they're able to orgasm, right? And also tell them it's normal if they don't orgasm from penetration. So I think that is a basic thing that we often forget to ask. We assume people know. So there's that aspect of things. Obviously, screening for diabetes, education around diabetes is so critical, right? I mean, we've learned with male patients, explaining to them that their diabetes can lead to erectile dysfunction and orgasmia and ejaculation. Like that's huge. But it does all the same thing in females. And, that can be a gateway to obviously glycemic control. So educating about that, issues of let's say lubrication, again, a huge hormonal component. So if you have perimenopausal, postmenopausal females, no matter how horny they are, if you don't have the correct estrogen supply to the tissue of the vagina and the vestibule, then they're not going to be able to become lubricated. That's just like basic. And interestingly, if you go back to the correlation, I'm getting esoteric here, between the vestibule, right, which is the homologue of the male penile urethra, the lubrication that comes from that tissue, right, is the female equivalent of pre-cum. So it's like the equivalent of there's these minor vestibular glands, and they're the equivalent of like the glands of Littre, or however you're supposed to say that, that you see when you're cystoing a guy, and you see those little dots along like the 12 o'clock position as you go through the penile urethra. And those are like nature's initial lubrication front in both men and women. And so, doing topical therapies, which I know we'll get into, can really address that. And on top of that, if you have somebody who's breastfeeding or on hormonal contraceptive, then those tissues also could be really under estrogenized and can also benefit from local treatment. And you can definitely give premenopausal females, for example, topical estrogen, whether they're breastfeeding, whether they're on, oral contraceptive pills and have, signs of low hormones in that tissue. So kind of, anorgasmia, let's see, we're addressing the hormone aspects. And then, another thing, like I say, that is so vastly underappreciated with all sexual dysfunction, male and female, is the connection between, like, underappreciated the connection with nerve issues, right? So a lot of people obviously like to talk about the pudendal nerve, pudendal nerves that run through your pelvis, that you have pelvic floor dysfunction, tight muscles that can, kind of cause pain with sex, can cause sexual dysfunction. But on top of that, lumbar sacral spine disease is so dramatically overlooked here, right? So, I mean, obviously we know, like, the spinal cord ends around, I think, the like L2 level, and then your sacral spinal nerve roots pass through your whole, like, basically, like, lumbar sacral spine area, and then they come out and innervate, obviously, like our penis and clitoris and other pelvic organs. And if you have issues with, let's say, your L4, L5 disc, that can cause aberrant sensation in, even your sacral organs, because you're having, the nerve roots to that area pass through. I know I'm getting very specific.
No, but I think it goes back to the physical exam, doing a good, back exam, maybe a focused neurological exam for sensation, not things that we would think about necessarily every time, but they're still squarely in our wheelhouse.
Yeah. And, whether male or female, I have people come in with, like, painful female sexual pain, conversely penile pain. And it turns out that they also, every time they have their penile pain, they're having, like, radiating pain down in their foot. And it's like, that person needs to go to the spine clinic. Like, you're not going to fix that problem. And we just, like, somebody was giving them, Emla cream for their penis. So it's like, that's not going to help them. Like, then they're not going to feel their penis. Like, they don't want that. Like, you know what I mean? And we try to look for covert Peyronie's. Like, come on. Like, that's, like, no, it's just, if somebody had radiating pain in their hand, you'd be like, oh, like, look into your neck, right? And, like, you just think that the penis and the clitoris and our genitals, like, float independently from the rest of our body, and they don't. So
talk a little bit more about vaginal estrogen, if you don't mind, kind of where you see that kind of fitting in with respect to, kind of the full spectrum of arousal, orgasm, pain, and desire. I think you've suggested that it's a generally underutilized, super straightforward intervention for urologists. Can you talk a little bit more about that?
So this is something also I love my residency program. I think they gave me great education, but I don't think the word, vaginal estrogen came up once in 6 years. And in my current practice, it's hands down one of the most utilized interventions. It's probably vaginal estrogen and Cialis are, like, the two main things I prescribe. So as a urologist, this is totally our lane. If you look at, the newest AUA guidelines on management of recurrent urinary tract infection, they recommend giving all perimenopausal and postmenopausal women with recurrent UTI vaginal estrogen, providing there's no contraindication, which there's very few. And the data supporting this is excellent, right? So there's even, if you look back, there's a publication in the New England Journal in the 90s showing that if you give low-dose estrogen to women who are postmenopausal, perimenopausal, that what it does is it raises the vaginal pH and allows, the lactobacillus, which is the normal flora in the vagina, to repopulate, and that it lowers the rate of urinary tract infections. Okay. So this is something we've known for decades, and it has not been ubiquitously employed, right? I mean, the vast majority of postmenopausal women coming in with recurrent UTIs have not been offered this. I mean, it's crazy. Like, it's absolutely crazy. I mean, that's excellent evidence. So And on top of the risk of urinary tract infections, right, there's something called GSM, which is genitourinary syndrome of menopause. And the symptoms of that, in addition to recurrent UTI, are recurrent UTI-like symptoms when there's no infection, right? Burning, urinary frequency, urinary urgency, pain with sexual activity, poor lubrication. So all these things that oftentimes are miscategorized as overactive bladder or, infections when they don't have it, or interstitial cystitis. And it's not saying that those conditions don't exist, but this is the number one first line therapy for any of those symptoms in any woman who is peri or postmenopausal, 100%, because the tissue is not healthy until you get them on that. And until you get them on that, all of your oxybutynin prescriptions are a poor second. You know what I mean? Like you have to start with the basic, which is reestablishing the health of that tissue. So how many patients is that, right? It's a ton. And I say this as a urologist that it's important for all of us, because let's say you're an endourologist and you have any single patient who's a peri or postmenopausal female. Well, if they keep getting a urinary infections, it's going to mess with the ureteroscopy you have to do or the PCNL you have to do, right? So this is important for all of us. It's not like a niche thing, right? If you have, a urologic oncologist, if you have a, bladder cancer patient and you're doing your surveillance cysto and they keep getting UTIs, it's going to mess with the diagnostic value of your surveillance cystoscopy, right? Because they have inflammation and they have a positive culture. If you're trying to give somebody BCG, it's so critical. And this can radically reduce the need for antibiotics, antibiotic stewardship. So it improves all of our lives. So I'm ranting on, but it's so basic. It's part of all of our practice. It improves the quality of your patients' lives. And these are my happiest patients. I mean, I'll also talk about your Press-Ganey scores. I mean, I've prescribed them vaginal estrogen after they've been getting rounds of antibiotics for decades, and they come in and they hug me, and they never come back to urology because all their problems were fixed. I mean, it's incredible. So don't feel like you're doing a service just to your patients. You're doing a service to yourself. So in terms of how to prescribe this stuff, before I go further, do you have any questions about that?
No, I mean, my head was kind of spinning with ideas, exactly in this space. I mean, it's pretty appealing to think about like a randomized controlled trial for patients receiving BCG who, get infections, get frequency, urgency, pelvic pain, dysuria, and, how simple would it be to do a randomized trial of, female patients, half of them getting vaginal estrogen and the other half of them not. Certainly something that I think I could immediately take away into my practice. Yeah. But yeah, my next question would be, how do you recommend prescribing it? So I think we're spot on.
So this is also so easy. So you don't require, right? If they're peri or postmenopausal, there's nothing you have to do to diagnose this. Even if you did a video appointment with a patient, you just ask them, hey, are you postmenopausal or are you perimenopausal? That's it. You don't even have to do a physical exam. They have that condition, right? That's a fact. Any woman who is perimenopausal, postmenopausal, and has any urinary tract symptoms whatsoever, they qualify. I mean, that's it. It's basic. There's almost nothing you have to do, so it's easy. You've diagnosed it. In terms of prescribing it, so what you want to pick is some of the low dose formulations. And we're talking about the vaginal formulations, right? So there's creams like estradiol estrase is a common one. The way they dose it is that they use what we say is like 1 gram. And you'll see on the prescribing information for these things, but you use 1 gram every day for 2 weeks. And then I tell them to use 3 times a week for the rest of their life. And that's it. And you don't have to monitor anything. That's it. And I tell people they're like, oh, well, if my symptoms resolve, do I stop it? And I say, you never talk to your dentist and say, when can I stop brushing my teeth? I don't have any cavities, right? Like the menopause doesn't reverse itself. So you just put them on it and they stay on it forever. And they're like your happiest patients. Other formulations, if they don't like the cream and they think it's messy, there's a vaginal insert. It's called Uvifem. You do it the same way every day for 2 weeks. And then 2 times a week forever. There's one called E-string, which is a little vaginal ring that gets popped in and switched out every few months. Just look up, vaginal estrogen products. In terms of some really important things to know for prescribing. So all of those products come with this scary black box insert warning talking about increased risk of, blood clots, breast cancer, uterine cancer, right? Now, the really important thing to know as a provider is that all of those warnings are based off of the WHI study, right? Women's Health Initiative. And that was this critical study, right? I think it came out in the early 2000s or 90s that really made everybody turn away from hormone replacement therapy, right? And the important thing to know is that those outcomes, that black box warning, is derived from women taking much higher doses of systemic estrogen, right? So pills, patches, not the topical formulations, which are not in the long run shown to raise blood estrogen levels. They're not, okay? So, and if you look at the American College of Obstetrics Gynecology has issued consensus statements, the National Menopause Foundation asking the FDA to take those black box warnings off of the low dose vaginal preparations, and they haven't done it. But there's no good reason. It shouldn't be there. And the reason I say this is because those black box warnings make a lot of providers hesitant to prescribe it because they're like, oh, medical legally, I don't want to be involved in this, or, oh, this is dangerous, I need to monitor something, or your patients won't take it because they fill the prescription and they see that and they don't want to do it. So I tell everybody, ignore that. You can ignore it. You have you could find resources online showing the consensus statements that it's garbage and bogus. And when you prescribe these things, just make a pre-made educational sheet for your patients because you don't have time to go on and on about all this, but give it to your patients because they're going to be more compliant with that. And on top of that, for your own knowledge, there may be a transient rise in blood estrogen levels when they initially start this therapy as the vaginal mucosa kind of reestablishes itself. But in the long run, it does not raise blood estrogen levels. And because of that, there is no, like in somebody with a history of breast cancer or uterine cancer who's NED, I have no concern whatsoever about giving these products. If they're actively being treated, let's say with a, anti-estrogen, then I would reach out to their, oncologist. But that's almost the only reason to do that. And everybody else, you can just prescribe it with abandon. Now, there are certain things, right? They may get, like I said, some spotting initially because they have some systemic absorption initially, and they may feel irritated in the beginning as the tissue adapts. And you could just tell them that's normal and that it takes a few months for it to resolve. But I will tell you, this has made my practice so much easier. All these patients that come to me postmenopausal, lower urinary tract symptoms, overactive bladder, recurrent UTIs, and I put them on this stuff and they're like the happiest people. And, so that's really it.
Yeah, and I think just kind of familiarizing ourselves with it, hearing it again from somebody that, does this routinely is incredibly valuable. And it sounds like it, absolutely traverses both lower urinary tract symptoms, sexual function disorder, pelvic floor disorder. And, I kind of jokingly tell urology residency applicants that, if you can help people pee and have sex and not have pain, in addition to eating and sleeping, to be involved in that, you're kind of halfway there.
Totally.
So it sounds like this is a really, really nice way that we can intervene and globally affect sexual health in women. And I'm very excited to kind of start implementing this in a big way. I think I've probably prescribed vaginal estrogen like twice in like a kidney cancer patient that also had urinary symptoms, and I prescribe it, and I haven't seen one of my colleagues in more of the kind of female sexual medicine function. But and I imagine that this also has benefit in pain with sex.
100%.
So in addition to the vaginal estrogen, can you talk a little bit about things that you advise for patients that are having pain with sex? You mentioned lubricants earlier, but some of the 101 things that are important for that?
Obviously, it's important to break it down, right? Are they having pain like with arousal? Because if they have pain with arousal, then it's potentially something like an issue with their clitoris, right? Like as the clitoris gets engorged, if they have clitoral phimosis, that could cause pain with arousal. If you're talking about pain with penetration, then a basic question would be, do you have a pain initially on entry, or do you have a kind of a deeper pain? And that can kind of speak to potentially two different issues. Although oftentimes they're committed that you'll have two issues at once. And what I mean by that is, irritation of that tissue, the vestibule, which surrounds the opening to the vagina and where the urethra is. If somebody has an issue with that, so there's an issue called like hormone-mediated vestibulodynia, then that can be, again, something related to hormone issues. And so there are people, again, let's say, who have that during lactation, and you put them on a vaginal estrogen, and that will treat the irritation of that vestibule tissue at the opening. Again, on physical exam, if you take a Q-tip and put it in that area and they have pain, then it's something that can be addressed. So, that's a basic one. And then, if it's deeper pain or even both, always checking the pelvic floor is really key. And any of these patients I'm sending to pelvic floor physical therapy. I mean, pelvic pain with intercourse is so traumatic on the body. And even if it starts with something else, let's say vestibulodynia, they can develop a secondary pelvic floor spasm from that. So, there are obviously other treatments that can be done for pelvic floor. Some people do trigger point Botox injections, etc. But really, the first thing always is send them to pelvic floor physical therapy. Find the pelvic floor physical therapist in your community. You don't have to be a specialist in pelvic pain to refer to them. These, again, are my happiest patients. I mean, I had a patient come back to me the other day and they're like, my favorite doctor is you and my physical therapist, and there's a value also to you in the sense that they're going to spend hours with this pelvic floor physical therapist, and that pelvic floor physical therapist is going to get an incredible physical exam, is going to get incredible history. And so if you have a complex patient with pelvic pain, they're doing a lot of the work for you. I mean, it's like making your life easier, right? Like, it's amazing. Like, send them. So, I think those are the basic things I would state, low threshold to assess hormone deficiency, to prescribe vaginal estrogen if needed, and to send to pelvic floor physical therapy, and not assume somebody has something like interstitial cystitis. Again, I'm sounding like I'm bashing that. Obviously, that's a whole other subset. But, you want to address other things as well that could be, the root cause of their symptoms. So,
no, I think, it's easy to be dismissive. It's certainly super easy to never bring it up. And, the kind of takeaways from me, and, admittedly, it's going to take a while to kind of incorporate, or if you don't ask the questions, you're never going to know.
Yeah.
And, there's going to be, I think, a lot that comes along with that. Just kind of off the top of my head, is it appropriate to have a chaperone in the room? Is this best done with the patient only, or ideally with the patient's partner? I think there's so much more to this that I've still got to kind of synthesize in my own brain, but you've got to ask the questions. Yeah. Don't be dismissive. It's massive from a quality of life perspective, and you may have an opportunity to really help patients out both in kind of GU and sexual function with relatively safe interventions.
Can I also, as a comment on kind of from the, oncology side or general urology side and research questions, genital urinary syndrome of menopause, I am very confident is an extremely high factor in inappropriate, or non-oncologic based, microhematuria in this population, right? Because they have, kind of this friable tissue at their urethra, and they all come in and they get their imaging and they get their cysto, and it's all negative. And I put them on and every single one of them needs to be on vaginal estrogen. And I put them on, and their microhematuria resolves, and in a great number of cases. And I think this kind of, idiopathic microscopic hematuria, or even on occasion, mild gross hematuria in this population is just like undiagnosed GSM, and we're just not we could stop all these inappropriate evaluations with this intervention, and that's a great way that these people are coming into urology, and we can intervene on it. So,
for me, Ashley, this has been incredibly useful. Of any podcast, I think I've just sat back and enjoyed learning and listening, and there's so many other things that have kind of popped in my head. Post radiation therapy, gynecologic surgery, sex with partners that have multi-component penile prosthesis, spinal cord patients, paraplegics, quadriplegics, and maybe just to hold the interest of our listenership, we can save that for another day. But I did want to, see if you had any kind of last minute advice for maybe not just urologists, but for patients as well, as it pertains to female sexual dysfunction.
Yeah, I mean, for patients, I would say be your advocate. The awareness in the medical community to treat this stuff, unfortunately, is not. It's making tremendous strides, but it's not there enough yet, right? Like, we've gotten to the point where all the men coming into urology are getting their erectile dysfunction questionnaires, prostate, associated with their prostate cancer screening, right? Like, I bet you, if you ask women who with a gynecologic malignancy or a urologic malignancy, like, are they getting sexual function questionnaires when they come to the office? Probably 0%, maybe 1%, right? So be your own advocate, because medicine is working to get there, but we're not there yet. So go to your doctor and say, I have pain with sex. I'm interested in this treatment. And fine, doctors don't like people consulting Dr. Google, but, I think there are instances where you have to be your own advocate, and this is one of them. The other thing I would say, which I didn't really touch upon, is there are so many resources. So ISHWISH, the International Society for Women's Sexual Health, is a great organization for, it's a kind of multidisciplinary organization, but there's plenty of urologists there. They have excellent courses, like in person, and also they have tons of online material. Of course, you can become a member of ISSM or SMSNA, which are International Society for Sexual Medicine and the Sexual Medicine Society of North America. But I will say ISHWISH is kind of the go-to if you want to do female sexual health education. They have tons of CME resources. So to patients, be your own advocate. To physicians, check out additional resources. From a treatment standpoint, I think, like we're saying, just examining the clitoris, examining the urethral meatus, the opening to the vagina called the vestibule. Those are urologic organs. Think about them as the analogous to what they are in the dudes, and then you'll feel a lot more comfortable. It's not crazy. It's just rearranged. And vaginal estrogen all day, every day. Your life will be so much better no matter what sort of doctor you are. I mean, I will tell you, this is crazy. I had a tweet about this that went pretty big, like mildly viral, a few thousand, likes and retweets. And we actually got one of the emergency medicine publications to do an article about vaginal estrogen, and it's coming out next month, with the idea that, like, if they're seeing women coming in with pyelonephritis all the time in the emergency room who are postmenopausal, that they can start this prescription too, because it requires no monitoring. And they could potentially reduce ER visits and overall healthcare costs. So this is something that's like, just vaginal estrogen all day, every day. It's great for all urologists. It's great for other doctors, emergency, primary care, whatever. So those are my takeaways.
That's great, Ashley. Well, thanks again. It's been incredibly educational for me, and I certainly hope so for our listenership. And thanks for taking out the time. There seems to be, like, we've covered a lot, but it's the tip of the iceberg, and, appreciate everything you're doing to really advocate for both women's and men's sexual health. Thank you.
Yeah, thank you for having me.